on femtosecond laser dial. I can move on to my next talk, and then we'll have Dr. Namrata give her final 2 talks. So looking at what the role of femtosecond laser in making intrastromal pockets. So we know that it can make a superficial cut. It can make a, you can use it for DALK. So what else can it be used for? It can be used for making intrastromal pockets. So you can use it for intracorneal ring segments, such as the intacs, and they basically act by adding volume to the cornea, and the corneal fibers are stretched, thereby allowing the ectatic part of the cornea or the corneal curvature to flatten. So you have the other rings, the Ferrara rings or the Kera rings, and in the surgical procedure, it's much simpler as compared to the manual technique of intacs placement that we were doing, because that had a vacuum suction ring. And for me, the problem was the centration, because if your vacuum ring does not center very well, it's very difficult to get your manual dissectors to go into the same plane. So here you mark the geometric center of the cornea, apply your femtosecond laser, and create the channel. The advantage is that you can create individual channel for the inferior and the superior segment, and you can match the width of the channel according to the size of the ring that you are implanting. So you can choose, you want a 450 inferiorly and a 210 superiorly. So your channel width of the channel will be according to the size of the intact. So it will not be the same size as what you do when you create it manually. And the best part with the femtosecond laser is that the depth is uniform across the cornea, as when you are doing it manually, sometimes there is a little hesitancy when you are working at a deeper plane. So sometimes you get an asymmetric depth. That means when you start, it's kind of a little superficial, and on the later half, it's a little deeper. So here, the channel created is much better. So this is a patient with advanced keratoconus, asymmetric cone. So we are putting in a 500 micron Intax SK single segment. And you can see that putting in the segment, there is not much of, and this is done under topical anesthesia. We can do it in the laser room itself, and it doesn't require, it's a procedure that takes only about 5 to 10 minutes, and you can insert it very easily without significant amount of manipulation. And because the incision is so precise and there is not much of gaping of the incision, you can even leave it sutureless. So most of the time when we use the femtosecond laser, we don't prefer to put a suture, whereas when you are doing it manually, you usually prefer to suture, because the initial incision opening tends to gape a little, and you don't want any epithelium growing into the interface. So if you look at, that's the Intax SK, what we used to do earlier, and that's the Intax. That was the regular Intax with the hexagonal outline. That's the Intax SK. That's the nomogram that you can follow. So if you have a cone that's within the central 3 to 5 millimeter area of optical zone in the posterior float, then you use a symmetric. If it is outside the 3 millimeter zone, tend to use asymmetric. In my practice, I use more asymmetric. Sometimes, most of the time, I end up using a single segment. Like in this case, you can see pre and post Intax is a single segment done, and you can see the astigmatism is reduced from 5.76 to 2.42, and the cone has significantly, the decentration is reduced, and the central part of the cornea looks much better. This is again another patient with early keratoconus. You can see the impact of putting in a Intax ring. Efficacy has been shown in a lot of studies, and basically using the femtosecond laser makes it much more predictable. And whether you use the Intax or the Ferrara rings, the outcomes are pretty comparable. Although the amount of the induced higher order aberrations are higher when you use the Kera rings or the Ferrara rings, because they are much more closer to the visual axis. Result of cross-linking with Intax, in this study they found that Intax alone did better as compared to doing it along with cross-linking. And in this study they found that you do Intax first and do cross-linking later, the results are much better. So Intax are a good option for keratoconus and post-LASIK ectasia using the femtosecond laser. I don't do it for very advanced keratoconus, so my maximum K would be 56 or 58 diopter. There should not be any scarring. At the site of implantation, the thickness should be at least 450 microns. Single implant for me gives much better results, and especially for asymmetric cones. For symmetric cones or for cones which are more central, I think most of them are actually best spectacle corrected visual acuity are about 612 or better, so we do toric ICL in such cases. And if we have to do cross-linking, we usually do it a week later after the Intax. The other thing that you can use to make the pocket is the camera inlay. So that's a implant for correcting presbyopia. It's about 3 millimeter in diameter with a 1.6 millimeter central opening. So with the femtosecond laser at about 200 or 250 micron depth, you can create a pocket that's a 6.5 millimeter stromal pocket that's been created. And the key factor is the centration of the placement of the camera inlay, and that's done on the line of sight or the visual axis. So this has to be determined preoperatively when you see the patient on your device called the AccuTarget. This can also be done on the conventional topography, where you look at the difference between the pupil center and the line of sight and then decide how much you need to shift the centration. The implant is very thin. It's only about 5 microns, and you have to be very careful, because even the movement of air in the operating room can cause the implant to float out of the chamber. So you have to really open it very carefully, and once you put it, you manipulate it into the desired position, put a bandage contact lens, and then that's the patient. So this is a patient, 49-year-old female, and she required a 1.75 ad. She was not very happy, banker by profession. We did the camera inlay, and day one she was 6.6 NH. She was pretty happy with the outcome, and it does not impact your distance vision, unlike monovision. However, studies have shown that the near vision and the intermediate vision is very good, but the distance vision can get compromised in certain lighting conditions. So this is a 2-year follow-up comparison, and they found that the older the age group, the outcome is better. So if you look at in this study with a group of 3, they found that the older age group between 50 to 59 or 40 to 49, where the overall requirement for near ad was more than 2.5 diopters, the camera inlay did perform much better. The other thing that we have used is the KeraClear foldable artificial cornea. It's a 7 millimeter overall diameter, 4 millimeter central optical zone. It's made of a it's acrylic foldable biocompatible material, something similar to the intraocular lens. So it can be used where you cannot do a corneal graft. So basically this is a patient with macular corneal dystrophy, had glare, photophobia, had a pachymetry of 437 microns. We went ahead, we made a pocket of about 8 millimeter with a central 3 millimeter opening, and you can see that so creating the pocket is not a problem. You can create a pocket with the femtosecond laser, and here using the femtosecond laser, you can see that we made an 8 millimeter pocket and a central 3 millimeter central trephination from the central optic. So we open up the pocket, remove the central cap, and then we introduce the KeraClear implant. So this is basically like an artificial cornea. This is for patients who are not willing to undergo penetrating keratoplasty. So you can think about this. This is introduced into the pocket. This was done through the peripheral incision, but now there are small instruments, so you can actually introduce it to the central 3 millimeter opening. The flange can be introduced, one edge of the flange can be introduced into the pocket, and then you have a device basically like pulling out a tire out of the wheel. So it's something similar to that. You can introduce that. So that's what it looked post-operatively, and that's on OCT. So this patient did well. He improved up to 6.9, and he had a refractive error of about 9 diopters, so we had to give him a soft contact lens, put him on topical antibiotics, which he needs to continue long term, and a bandage contact lens to be there. These are some of the other implants done by Jose Vargas, and you can see that in failed grafts, post-chemical injury, they have done it for Reese buckler, for keratoconus. And if you look at another, without the femtosecond laser, you can also use like a pocket maker microkeratome, and you can implant this. And this is from George Alio, where they have done an epidecimetic implantation of the same KeraClear implant, but the optic part, instead of 300 microns, it's about 450 microns. So you do a manual dissection, and you put in the KeraClear implant, and then put a corneal graft on top with a central 3 millimeter opening. So it's advantage of using a femtosecond laser. It's a sutureless implantation, external procedure without entering the anterior chamber. IOP is unaffected, and if not, you can always go back and do the other surgical procedure at a later date. So by implanting this, you're not altering the outcome of any other subsequent procedure. So that's in short about the use of femtosecond laser and various intrastromal pockets. Thank you.